Welcome to AETCM, the Emergency Medicine channel. A 67-year-old female presented to ER with alleged history of slip and fall at home, followed by pain and restricted movements over the left hip. On initial 10-second assessment, airway was patent, no pooling of secretions, respiratory rate was 16 per minute, saturation 100% on room air entry bilateral equal. Coming to circulation, BP was 160/90 millimeters of mercury, pulse rate was 90 per minute, all peripheral pulsations equally felt bilaterally. GCS was 15/15 disability, pearl, pupils equivalent reacting to light, and left hip was, the range of movements was restricted.
Okay.
And patient was having pain, so we have given PCM, injection PCM 1 gram IV stab. On exposure, she was afebrile. Coming to history, a 67-year-old female who is a known case of hypertension, bronchial asthma, venous ulcers over the right leg presented to ER with alleged history of slip and fall at home, following which she was not able to mobilize by herself. No history of any head injury, loss of consciousness, seizures, vomiting or associated neck pain or upper limb pain or deformities. She was on Amlong 5 mg, fexofenadine 120 mg and inhalers. Coming to local examination, patient was lying supine. Left lower limb was externally rotated and slightly shortened when compared to right lower limb. On inspection, there were no external injuries, no scars or sinuses. On palpation, tenderness was present over the anterior joint line. And movements, left hip, the range of movement was restricted, ankle and toe movements were active. So we had taken X-ray of pelvis with both hips and left hip AP lateral, showing a neck of femur fracture, left side.
Okay, so it's a clear 67-year-old lady with an osteoporotic age group who has come with a trivial fall at home, having a neck of femur fracture. So that will be the classical history that we will be getting in for neck of femur fracture. So whenever you see a neck of femur fracture, what are the considerations that you wanted to keep in your mind? So first is, as you said, age group. Age group. So age group like above 60 and all, we are expecting 65 years and above, we are expecting probably an osteoporotic fractures. But when the age is less and the patient is coming with a trivial fracture, we need to think about pathological fractures. So whether it's a metastasis, Page's disease or whatever be the causes, we have to think of a pathological fracture. And another thing, the same fracture for a young patient, maybe 25-30, you have to consider the mechanism of injury. So it's a high velocity injury. So high velocity injury, you need to look for other fractures. Isolated neck of femur fracture as such with a high velocity injury, you need to definitely look in for other source of fracture. So that is regarding the neck of femur fractures. Now, coming to the next most important aspect is the pain management. Pain management is very crucial because once they move, it will be significant pain will be there. So what are your options available in your ED?
IV sedation means IV analgesics can be given, and then nerve blocks can be given.
Okay.
It is either femoral nerve block or lateral cutaneous femoral nerve block.
Okay.
And then tractions can also be.
Okay. So traction splinting can be done and also the nerve block. So can you elaborate what will be an ideal nerve block for this patient?
Femoral nerve block can be given. It can. It is like the patient will be in supine position, and we can give a pillow beneath the hip, and the lower abdominal fold should be retracted superiorly, and the nerve is located lateral and deeper to the femoral artery.
So you have to use ultrasound guided. So that is for sure. It should be ultrasound guided. Blind procedures are not recommended these days. So ultrasound guided. So the anatomically it is the vein, artery and the nerve. So from medial to lateral. So we know the inguinal canal, or you can look for the crease and you can palpate for the pulse, and you have an ultrasound probe. That is very easy. Then you locate the nerve, and how will you proceed with the procedure as such? What is the drug that you wanted to select? Femoral nerve.
Okay, or BP vaccine.
Without adrenaline? With adrenaline.
Without adrenaline.
Okay, then?
And then we can, that with nerve can be found out, and then with 30 ml of the local anesthetic can be injected.
Percentage?
10.
1%, 2%? Which one of the percentage you have available? Dosing of lignocaine?
1%.
Dosing. What per body weight, per kg body weight? So it is actually, it will change from patient. What is the maximum dose? What is the minimum dose? You should know. So 30 ml of 1% is what routinely we will do. But Maybe for an obese patient, you need to give a little bit more. Maybe a lean patient, you should not go to that extent. So 0.01 milligram, what will be the dosing? I don't remember exactly the dosing. Should know the dosing approximately. Now, whatever be the regional blocks we are giving, we are actually not calculating according to the body weight. We are assuming just taking 15 ml, 20 ml and giving. But ideally, it should be calculated according to the body weight, and we should be administering the maximum or the minimum dose that is required to produce the analgesia for the patient. So, once you infiltrate, how long you are expecting this nerve block to act?
15 to 30 minutes.
15 to 30 minutes, then why you want to do a procedure like this? It will have much more prolonged action. It will be nerve block, it will usually you will be able to get a minimum of 2 to 3 hours minimum. And sometimes you can exceed also. So, minimum you will get that much effect for the patient. So that is the major reason. You will have significant pain reduction. At that time you can do all your manipulation, sending a patient for an X-ray, and before that only thing what we need to do, distal neurovascular deficit we need to check in for. But are we expecting anything in femoral fracture? Usually we don't see any of this thing unless and until the femoral neck blood supply can be in trouble, but that we will not be able to assess right now. So the distal vascularity usually it is unaffected unless and until you are having a mid-shaft femur fracture also due to the trauma and all. Then you need to consider, okay, we should be avoiding these things, but still you can give after giving your assessment. After doing a proper neurovascular assessment, you can still prefer the block. What are the other options? Lateral cutaneous nerve?
Fascia iliac compartment block. It is given as, we will draw a line between the anterior superior iliac spine and pubic tubercle, and it is divided equally into three parts. And at the board junction of the middle 1/3 and lateral 1/3, we will draw a perpendicular line around 2 centimeters, and the USG probe is placed in a transsectional view.
Okay.
And then we can apply with a needle of 30 ml of 1% lignocaine.
Okay. So that is again for your lateral cutaneous nerve. So these are the two options. Then you have the skin traction, as you said. So skin, how will you apply a skin traction?
Skin traction will be applied with an adhesive tape, usually below the knee, and then it will be attached to a weight of maximum of 3 to 5 kilos. It is mainly used in children, and skeletal traction is mainly used in adults.
But majority of the time we use seeing them putting in skin traction. Maybe 10% of the patient body weight is what usually they recommend for a skin traction. Skeletal traction? Skeletal traction is mainly
by the K wire or Steinman pin through the bone we can apply. So the direct force is given directly to the bone. In skin traction, the force is applied by the skin, and it will transmit through the fascia and muscles and to the bone. And this is a maximum of 15 to 20, but we usually give 7 to 10.
Okay, again it's for a mid-shaft fracture and all, mid-shaft femur fracture and all, skeletal traction will be much better compared to a normal skin traction, which will not produce any major effect. So that is the difference. So that is the pain management. Now coming to X-rays. X-ray. So after X-ray only we will go ahead with this procedure. So X-ray, what all views you want when you are suspecting a neck of femur fracture, or it can be intratrochanteric fracture, or it can be, what are the three fractures? It can be intratrochanteric or subcapital fracture, or you can have the transverse fracture. Then what all views you want?
Pelvis, bilateral pelvis we have to take.
Always take bilateral pelvis. That is the first thing. You have to look for the
Shenden's line.
Shenden's line. So you'll be able to compare with the normal side. So always you make sure that you are taking a bilateral pelvis. So you'll be, because sometimes the overlapping fracture, the fracture line and all, will be missing that. So always you do a clinical examination, go ahead with the X-ray and draw the Shendan line, and if there is any interruptions in the Shendan line, you have to consider there is a possible fracture. Then
the affected pelvis, AP and lateral views to know about the displacement.
Okay.
And
so how will you classify this neck of femur fracture?
Neck of femur fracture can be either anatomical classification like subcapital, transcervical and basal, or by Powell's classification that we usually don't do with
Powell's classification is more into angulation, no? 30 degree, 40 degree. We usually do the Gardner's classification.
That is grade class 1 is with undisplaced, means only impacted fracture. 2 is complete fracture but without displacement, and 3 is minimally displaced and completely displaced.
So this 1 and 2 you might have some difficulty in finding out in the X-ray. So that is a group of patient when you are not conclusive in the X-ray, you might need a CT. So that is the only 1, 2, 3 and 4 we will be able to see in the X-ray. 1 and 2 might be difficult. So it's always clinical. You have a tenderness, X-ray is not very clear. Go ahead with a CT and conclude the diagnosis. Okay, then.
Then coming to the management, actually the neck of femur fracture can be displaced or undisplaced. Undisplaced by with screws we can manage. If it is displaced, we have to know the age of the patient. If it is less than 60 years and more than 60 years. If more than 60 years, we can we have to see. I mean, mainly the processes management we will do. And if it is also normal, if the hip is normal without any arthritis, we can do hemi-arthroplasty. If it is with arthritis, complete hip replacement have to be done. And for the less than 60 years, we have to reduce the fracture under X-ray. If it is reducible, then we'll give the traction, and if it is not reducible, we'll have to open reduction and with fixation.
So that is surgical part which we are not at all interested in. But one part I am very much interested in is what will be the thromboprophylaxis that you wanted to start for this group of patients. Because this neck of femur fracture, they are the most potent group of patients who can develop a fat embolism, maybe shaft more prone, but neck of femur, they are really immobilized for long and they are more prone to develop pulmonary embolism. So what is the strategy for your thromboembolism prevention? You have three options, right? You have unfractionated heparin, you have fractionated heparin, you have fondaparinux. Okay, so definitely that patient will be taken up for surgery. So usually before surgery, what we'll say, stop heparin. So how will you decide? Because this patient will be lying down like this and he will definitely at a higher risk of developing a pulmonary embolism. So what is the option and when you want to stop before the surgery?
Heparin can be stopped.
All patients, you start one of the agent, either unfractionated heparin or low molecular weight heparin. And before 6 hours prior to surgery, you can stop these agents. So some surgeons recommend 12 hours, but 6 to 12 hours is what the timing. So you start on immediately. If you are not planning, there are no other contraindication. Immediately you start on the prophylaxis with either unfractionated heparin or 5000 unit TID, or you start off with your low molecular 0.6 ml OD for your DVT prophylaxis. That is the first one. And after the surgery, once the surgery is done, 6 hours later or 12 hours later, you restart your anticoagulation. So that is the key thing. So first 1 month, almost the first 1 month, we need a proper anticoagulation to prevent thromboembolism. So if still the patient is mobilized actively, till that time we need to consider this. So the first 30 days is the crucial one. And neck of femur fractures has got, among all the fractures, just got high mortality. So around 6% mortality is there. And if the age increases, the mortality rate again increases. So that is the one thing. And you have another option is fondaparinux. So fondaparinux should not be given prior to surgery, because there has been incidents where it will cause epidural hematomas if you are planning for a local anesthesia. So if you are planning for a local anesthesia procedure, fondaparinux should be avoided pre-operatively, but before the operation, and after the operation, definitely yes, you can start fondaparinux. So three options we have: unfractionated, low molecular weight heparin, or fondaparinux. Fondaparinux not prior to surgery. All other two you can give prior to surgery and after the surgery also. 6 hours you can remember. 6 to 12 hours, 6 to 12 hours you can remember. So that is the most crucial one in preventing, because the major mortality is not surgical related mortality that you will see. Its major mortality is related to the embolic events that is happening because of the immobilization of the patient. So as an ED physician, it is our crucial role to administer one dose immediately. If you are diagnosed, like the patient is been here for 12 hours, 6 hours after the injury, he will be lying unmobile. So the orthopedician will come and he might miss writing this, but definitely make sure that you are starting on a thromboprophylaxis for preventing DVT, thereby preventing your pulmonary embolism. Okay, so anything else? How will you differentiate between all these three fractures, intracapsular, extracapsular, and by intratrochanteric? So these all can present with the neck, hip pain. So
neck of femur is usually intracapsular, and intertrochanteric will be extracapsular. So the external rotation and that shortening will be more profound in extracapsular fractures. So in intertrochanteric it will be so much differentiated.
Subcapital? Might not be able to see any shortening. If it is a phased and like this, there might not be any shortening that we are able to see. So these are the major differences. And again, CT might be needed for a missed IT. IT fracture we can easily miss. I'm not neck of femur we can miss. We are not expert. Sometimes we can miss these fractures. But most important, when you have a clinical suspicion, you have to have a radiological confirmation either by an X-ray or by doing a CT. Okay. Then anything else that you have prepared for? Complication of vascular necrosis. So why there is a vascular necrosis as one of the major complications?
Cervical fracture means neck of femur fractures. The arterial supply of the neck is like from foveal artery and retinacular arteries and medullary arteries. So if there is it is from distal to proximal. So if there is any fracture, that proximal area will be will have cut off the circulation. So,
okay. So that is your. What if the same? I'm just asking for the purpose of discussion. So I'm giving another. This is an adult patient with a hip joint pain. I'm telling you another age group, like a 10-year-old boy has come with a hip joint pain. 10-year-old child has come with a hip joint pain. So what will be your differential diagnosis for a 10-year-old boy with hip joint pain?
Congenital slippage.
Perthes disease, yes. 3 things that you need to keep in your mind. One is Perthes disease. Another one is transient stenosynovitis. So that the classical history, the child had some fever, cough, also some upper respiratory, some infection. And after that, the child is complaining of very common presentation. Post this viral illness, the child will come with an hip joint pain and they are unable to move, unable to weight bear, significant pain, transient synovitis. Then, slipped upper femur head. Epiphyseal head of femur. So SUFI. So that is the slipped upper femoral epiphysis. So these are the 3 differential diagnoses for pediatrics. Since we are discussing a hip joint, I thought of discussing that. One is X-ray. Perthes disease X-ray will get. Slipped upper femur epiphysis also will be able to get into the X-ray. But this transient tenosynovitis is where an ultrasound will help initially for the diagnosis and later on by doing an MRI of the hip. So these are the 3 differential diagnoses that we need to consider. Perthes disease, again, you will have some history, maybe some family history will be there for Perthes disease. And something on, it will not be an acute presentation, but the pain worsens, it will be an acute presentation. Maybe the child will be having some minor trauma history they will be saying, but the presentation will have nothing to do with that. And after that, they will come to this. With fever, this is what, and again, with a trauma, slipped upper femur epiphysis is also one of the differentials. Since we are discussing, I thought of doing that. Okay, thank you.